Assalamualaikum and good morning. My name is Anas from Arthro team. So our patient for today's radio conference is Puan Siti Baizura binti Ismail. She is 42 years old, Malay lady, work as a government school teacher with no medical illness. Presented to our clinic with complaint bilateral knee pain for 8 years, progressively worsening pain during activities, during climbing up and downstairs. Otherwise, patient deny any knee swelling, no knee stiffness, no instability, no history of trauma. Patient had bilateral knee PRP injection at GP, but temporarily relief only lasts for 2 months. For the local examination of the bilateral knee, no knee effusion, tender at medial joint line, patella grinding test was positive, range of motion 0 to 140 degrees. MRI bilateral knee was done on 5th of June 2024. So our diagnosis is to rule out bilateral patella femoral chondral injury. So the objective for our radio conference is to quantify the defect area, percentage of the chondral injury, and to decide either for chondral repair or arthroscopic graft reconstruction. So I will pass over to radiology team.
Okay, thank you for the history. Okay, a very good morning to the respected professors, lecturers, and fellow colleagues. I'm Sita. I'll be presenting the conference for today. So we'll start with the radiograph of the bilateral knee joint performed on the 11th of January this year. So here we can appreciate there is reduced joint line seen at the medial aspect, on the left more than the right. Otherwise, otherwise there is no subchondral sclerosis, there's no osteophytes, there's no fracture seen, and the soft tissues are unremarkable. On the lateral radiograph on the left side, we can appreciate there is irregularity of the patella surface here, and otherwise the femoral femoral articulating surface is smooth. There's no irregularity seen. There's no osteochondral, there's no subchondral sclerosis, there's no osteophyte seen, there's no fractures. The soft tissues are unremarkable on the left side. On the right side, on the lateral radiograph, we can see there is irregularity of the patella region, surface at this region. Otherwise, the opposing femoral surface is smooth. There's no subchondral sclerosis, there's no osteophyte seen, there's no fracture seen, and the soft tissue are unremarkable. So we also have a skyline view done on 30th of April. Here we can see there's reduction of the medial joint, the patella femoral joint space seen bilaterally, more appreciated on the right side. And we also can appreciate there's irregularity of the patella surface seen more appreciated on the medial aspect. Otherwise, the opposing femoral surface is smooth. There is no subchondral sclerosis seen. There is no osteophyte seen. So now our impression for the radiographs would be features of bilateral patellofemoral osteoarthritis changes. So moving on to the MRI done on the 5th of June. We'll start with the right side. Okay, so here at the area of interest, so at the area of interest at the patella region, we can see irregularity of the patella cartilage as seen at the previous radiograph, and there is also full thickness defect seen at the junction of the patella cartilage at the medial and lateral facet region here. It measures approximately 0.9399, about 1 centimeter, with a depth of approximately 0.2 centimeter, and also the length would be approximately 1.6 centimeters. There's also another area of focal high signal intensity noted within the patella cartilage, measuring approximately 0.5 centimeters with a depth of 0.17 centimeters. And at the sagittal, we can appreciate that's approximately 0.5 centimeters at the medial facet of the patella. There's also adjacent bony changes that we can appreciate here. There is multiple areas of well-defined hyperintensities in keeping with subchondral sclerosis, subchondral cysts. Here we can see multiple subchondral cysts. There's also areas of ill-defined hypointensities that we can appreciate both on PD and also T2 spare in keeping with subchondral sclerosis. Otherwise, the femoral articulating surface is smooth. There's no high signal intensity noted. Other findings would be, positive findings would be there is high signal intensity noted at the posterior horn of the medial meniscus in keeping with the intra-substance changes. And also there is also there's also high signal intensity noted at the insertion of the lateral collateral ligament here in keeping with a sprain. Otherwise, the rest of the visualized ligaments are unremarkable. They return to normal signal intensity. Other miscellaneous findings on the left, there's a right knee joint effusion noted extending to the suprapatella and the posterior knee region. Otherwise, the vascular bundles, the muscles, and the other bones are unremarkable. So moving on to the left knee joint. So again, at the area of interest at the patella region, we can see irregularity of the patella cartilage both at the medial and also lateral facet region. There's also a full thickness defect noted at the patella cartilage at the lateral facet region, measuring approximately 0.9 centimeters, and then with a depth of 0.28, and then corresponding to the length would be approximately 1.4 centimeters. And then there's also a full thickness defect noted at the patella cartilage at the medial aspect. This measures approximately 0.7 with a depth of 0.2, and the length measures approximately 0.4 centimeters. There's also adjacent bony changes. We can appreciate there's multiple well-defined high signal intensity in keeping with subchondral cysts, and there's also multiple areas of ill-defined hypointensities in keeping with subchondral sclerosis. We can appreciate that the femoral articulating surface is smooth. There is no high signal intensity noted. Okay, the rest of the ligaments are unremarkable. They return to normal signal intensity. Miscellaneous finding would be a left knee joint effusion extending to the suprapatella and also the posterior knee region. So my impression for this for the MRI would be features of bilateral patellofemoral chondromalacia grade 4.
Thank you, Sita. How about the posterior horn on the left side? Is it affected or normal?
No. On the left side, The posterior horn is not affected. Yeah, I'll show you. So it's, as we can see here, if there is no abnormal signal intensity, no high signal intensity noted at the posterior horn of the medial meniscus.
On lateral also.
This is lateral meniscus.
Sorry, this, yeah. So yeah, we can see here this medial. There is no increase in signal intensity seen.
Okay. Can you show again on the right side? The one that
On the
you
right
said,
side, okay, sure.
the abnormal signal.
So on the right side, with this one. Sorry. Yeah. So here we can see there's a high signal intensity that's not extending to the articulating surface in keeping with extra substance changes.
The root, okay?
The root is
Or is it
okay.
just intra-substance? The
Yes,
posterior
the
root
root
is
is
okay. Okay.
Shooting what I do. Yeah, this okay.
So this one on medial side.
Yes, on medial side.
Okay. How about the cartilage area in the medial side, medial femoral medial femoral condyle? Is it okay? No defect at all?
I think to do this one. No, tak mau itu. So sorry, in the PD sequence, we can see that the the femoral articulating surface is smooth. There is no abnormal signal intensity noted. If compared to the patella cartilage over here, we can appreciate there's irregularity, where else the femoral, the opposing cartilage is very smooth, and it preserves its thickness.
Okay. So just
both on the right and left side. So it's
because
quite focal at the patella region only.
Okay, because on the X-ray we see the joint narrowing, so we are worried is there any chondral defect or not on the medial side. So from MRI confirmed that there is no defect. So this is mainly focal area on medial and lateral facet for the both side of the knee, right, Seta?
Yes.
So your conclusion is defect is more on the lateral facet, right, rather than on the
yes,
medial
it's
facet.
actually because on the right is actually at the junction between both the lateral and medial facet, and then on the left the larger defect is on the lateral facet.
Okay. Actually, we would like to discuss this case with radiology because we want to quantify the defect area of the cartilage. Because this patient is still young, 42 years old, active teacher, now affecting her activity as a teacher. So she already did somewhere in GP for injection. I think she already had a PRP injection. So nothing helped at all, only a few months only. Maybe that is the effect of the steroid, I assume. So this means that we have to think of what we should offer to her rather than doing replacement. This case referred to as arthroplasty for joint replacement. So I don't think at her age now is suitable for the replacement. So basically, as a part of discussion, we are normally offered for the chondral defect is either a repair, regenerate, or a replacement. So this one we will not offer her for replacement at the moment. So we are thinking of to quantify the defect area. So maybe we can offer her arthroscopic debridement, and then we do a nanofracture for the area that's a defect. So we would like to regenerate the area of the defects to become like hyaline-like cartilage later on. maybe the option that we have at the moment is we do a arthroscopic debridement and do a microfracture. And then the option we can put a scaffold for the area, and then we can inject the bone marrow or any stem cell like peripheral blood stem cell as well.
Okay. Rajai,
Yeah, Prof.
can you share with us the approach of a patient, middle age or elderly, with a knee pain, with clinical impression of osteoarthritis, where imaging are being used as a guide towards the form of therapy. When I say the form of therapy is medically drugs to alleviate the pain. When the pain could not subside with just drugs, then you go into whether to do any intervention. Intervention means, injecting drugs into the knee, for example, and not just a local, either short-acting or medium-acting, and perhaps, thinking of HA or steroid, and then going towards a bit more complex, using PRP or stem cell, and when to start using MRI, and if the cartilage mapping is necessary to guide you further, what form of treatment can be given, and you start saying whether a cartilage replacement or scaffolding. Can you give some idea? Because the reason why I'm asking is that, is there a set of protocol or algorithm to guide? One is the primary care, because most of the cases will see them first. Two, when they are referred or are seen by the orthopedic in the hospital, the juniors will have some guide towards what form of treatment could be offered. Thank you.
Yeah, Prof. This one, I'm from arthroplasty team. So normally we get this case because they referred for us for osteoarthritis. So normally we took into consideration that age and then the patient as well. So if more than 50 years old, we can assume that this is a wear and tear of the process of osteoarthritis due to aging process. So for let's say this patient come to me, 42 years old, active teacher, still doing her job as a teacher, have to climb the stairs and so on. So I would like to offer her better treatment, not for replacement, as a basic treatment for any cartilage injury or defect. You can offer repair, regenerate, or replacement. So I don't think that she is suitable at the moment for the replacement, because we think of the longevity of implant itself, whether patient maybe in 15 years later need another revision surgery for the implant for her knees. So we try to facilitate that we can offer like regenerative medicine at the moment, that being an option for the patient with cartilage injury. So that's why in this case, I would like to know how much is the defect in terms of to quantify the depth as well as the area of the defect in patellofemoral. So because we can target whether we can do the arthroscopic debridement and scaffolding with the area, and then add on with the mesenchymal stem cell to help for the regenerative for the cartilage area, and then later on can help with the pain itself. So unless in the patient with more than 50 years old, we think of there is towards aging process, maybe there is a lot of not only focal, but it's maybe there is a scattered area with the cartilage defect due to wear and tear of osteoarthritis progressive. So in this area, in this case, I think there is a focal defect only on patellar area. So we can offer regenerative treatment for this one, Prof. Otherwise, in osteoarthritis, more than 50 years old, wear and tear with guide of X-ray, we can help with the patient what is the option. Normally, if patient come with the OA changes from Kegler and Lauren, we can offer whether early or late OA. If early, we can offer the non-operative treatment, physiotherapy, reduce weight, and then a few exercises that can strengthen and promote the production of the synovial fluid inside the joint with the range of motion exercise. If fail, that one conservative treatment comprise of injection as well. If physio not help, and then the supplement, let's say there is a few supplement at the moment in the market to slow the progress of the OA, and then the injection can help to increase the lubricant inside the joint. If there is a fail, maybe another step is what we call it, can offer surgical intervention. If there is what we call it only purely medial side narrowing, and then the patient is still active, and then the alignment is a varus, we can offer HTO, high tibial osteotomy, to make sure there is a less pressure on the medial side. Normally, we offer for HTO in active patients who are willing to do active sport later on. Otherwise, we can offer the unicondyle UKA, unicondyle arthroplasty. That's only we replace on the medial side only. And then for this case, maybe later on, if there is also the defect on the femoral area, the trochlear area, we can offer patellofemoral joint replacement. And then the end of the story is the total joint replacement with total knee arthroplasty. If there is what we call it suitable tri-compartmental OA, including patellofemoral, medial, and lateral as well. I think that's the main strategy in our side for approaching patient with knee pain, Bro.
That's it. Now, you mentioned about in this particular patient, the pain relief lasts only for 2 months, perhaps more the effect from the steroid. I mean, in terms of research and application of PRP and stem cell, is to promote healing. And what we desire is for the cartilage then to grow and to replace the defect. Why do you think in this patient PRP doesn't help? Is it because of the size of the affected area, or still a PRP a controversial treatment to be given? Because nowadays, I mean, in social media, in advertisement, the stem cell comes out, stem cell from the umbilical cord, now people are doing stem cell, harvest from the period blood. So
yeah,
there's a lot of, people pushing towards this. Why it failed in terms of PRP treatment in this patient? Or perhaps, it didn't go into the joint space, it's gone into the soft tissue. Thank you.
Yeah. This one, PRP, like in the literature said, it's a sort of try to regenerate the defect area. So maybe there is not what we call it local treatment for the area. Maybe the area that's a defect will not sit on the patellofemoral, because on the patient, maybe they keep moving with the climbing stairs, downstairs, and the patella keep sliding on the trochlea. So maybe that area is not promoting the what we call it the regenerate area. So that's why it's keep on what we call it gliding to each other. So maybe that's what we call it what on the other side we can say that the limitation on the PRP side. If we do like arthroscopy and then do the direct microfracture on the patellar area, so that means that we can do the direct regenerate for the intention area. So maybe there is a more convincing technique that's to promote for regeneration for the area, Prof. Maybe we think of the PRP patient already did. So maybe the successful rate is not as high as the arthroscopy and microfracture and scaffolding for the area.
Fatah?
Ya, Prof.
Fatah?
Ya, Prof.
Do you guys have itu apa ni cartilage mapping? The MRI in 3T ke 1.5T. Do you guys have that now?
Unfortunately, no, Prof.
No. Rafai, from your reading or from your training or visits, you know, is there any center that routinely use cartilage mapping in view of choosing what sort of treatment to start? And do you personally believe that there is a big role and you would like to have that service to guide you?
Yeah,
for
Prof.
treatment?
I think for the way forward in the future, this area is what we call it evolving for the what we call it cartilage regeneration. So I think it should be we should have one for this one, because we want to delay the what we call it replacement or other more aggressive surgery. So this one we can control any focal area to make sure that patient have the regeneration on the defect area. I think I heard that if I attending that any cartilage society, or they have that kind of what we call it MRI that can help the surgeon to quantify the area, the deafness, and then we can prepare ourselves to make sure that we have enough what we call it scaffold, as well as the area that should be debrided intraoperatively. So I think that will be the future direction for the cartilage defect in terms of treatment, Prof.
Fatah, I mean, the knowledge that I have about cartilage mapping, one is whether the hardware that is already available is can do cartilage mapping. Number two is there must be software to go about doing it. So if the interest is there, if the need is there, or if the push is there towards having, probably can check on whether one is there the hardware is available ready or not, and two, then what would be the cost like to have the application or the software be part of the workstation. Yang tu yang saya faham dulu lah apa tu kata. Thank you.
Sorry, Prof. I would like to rephrase. I've misunderstood your question just now. I thought mapping in terms of the surface area, but actually we have the T2 mapping now. It already the software is been in our 3T machine, but just recently we explored about it. And we have planning for research on cartilage mapping and also meniscus mapping using the T2 value.
So what can it do? Can it will when you will give the quality and the quantity
Yes,
of the
color
deafness.
mapping. So the color coding, we can see the color changes and also the value, T2 value.
Okay. So probably you need to talk to the orthopods whether that's what is adequate for them to of the information in terms of to move forward to guide them what sort of treatment can they offer to the patient.
Dr. Fatah, so is it can show for this case for the color changes?
Oh no. You have to do another acquisition, image acquisition, and then usually more targeted at the region that we want.
Oh, okay.
Fatah, I think what Dr. Rafani is asking is the service can be provided to the patient if they want to have that information. I know that whatever you have done, it has to be done in other sequence ke macam tu kan. So
Yeah.
it can be done lah. Maksudnya
Yes.
tu.
What I understand from Dr. Rajat's question is for this particular patient, we don't have that mapping because we don't incorporate that during the scanning.
So Rajat dia tak buat.
We can do.
Okay.
Tapi kalau request is there,
Yes.
dia orang akan buat
okay.
and they'll provide you the information lah.
So
But
probably
we are still doing in process doing research for the to look for our population parameters because itu that we have in literature is from other population. So we want to see in our population.
Can you qualify our population, because pada saya is about our population is about population within the Southeast Asia. Kita ada etnik Melayu, kita ada etnik Cina, kita ada etnik India yang ramai lah, which is available in Singapore, which is available in Thailand, which is available in Indonesia. So kalau katakan ada data dalam area Nusantara ni, so that is a start to move on. Kalau katakan tak ada dalam Malaysia, tak boleh nak buat apa, saya rasa data-data sekeliling Filipina ke apa tu, pasal Nusantara tu ada data is quite adequate lah, saya rasa. I mean, that's how I look in terms of comparing what we tu, apa ni, these three major ethnic group lah. Terima kasih.
Untuk regional pun, I tak ingat Prof. Rasa kita masih tak ada reference data lah. That's why we try to evaluate in our population. Satu, lepas tu kita nak compare dalam. Sorry, I cannot recall exactly the objective of the research, but we are venturing into this T2 mapping lah for cartilage and also for meniscus.
Okay, Fatah. Actually, the software license is we get for research for the project only lah, not the routine clinical use lah.
Oh, I see. Okay. Why
we
tu, Jani?
We need to purchase if we want to have.
Okay. So it was installed part of the research punya arrangement lah. But not the clinical service.
Yeah, dia pun bagi limited time. I think kita kena collect acquire image dulu. Lepas tu masa analyze tu kita akan analyze in maybe in one month or 2 month dia bagi.
Sebenarnya pun tu pun yang the given time pun dah habis, dah expire.
Expire lah.
Kita boleh ask untuk ni lah extension.
Okay, I think later on we should have one for this one. Maybe that is maybe good for our service for what we call it in terms of managing the cartilage defect in younger population.
Yeah, I think for future MRI, new MRI, I think we should have this software to assess the cartilage. We have a T2 mapping and T1 mapping, and T1 ratio that is also quite useful for cartilage imaging.
Okay, Prof. Thank you, Prof. Okay, I think thank you everyone. Thank you, Prof, for the discussion.
Okay, thank you.
Okay, thank you.
Thank you, everyone. Assalamualaikum.